The topic given to me is DRUJ arthritis. Really, if it is arthritis that I have to talk about, the topic is very simple. If there is any arthritis, it requires treatment either by replacement, fusion, or excision of the joint, and that would be actually end of it. However, so for DRUJ arthritis, the choices would be for replacement, you have ulnar head, hemi or complete total replacement, or a Shaker's prosthesis, DRUJ prosthesis, fusion in a form of Sovaco-Panji procedure, or excision in the form of direct procedure, and that would be end of this talk really. However, I would like to phrase my talk not as DRUJ arthritis, but a painful DRUJ, and the arthritis could be one of the causes for painful DRUJ. There are so many other causes for painful DRUJ, some of them acute, some of them chronic. Many of the acute conditions would eventually lead to chronic pain and arthritis. So that's where I begin my talk. Dr. Sanj Kakkar and Mark Garcia Elias have given us a fantastic algorithm for assessing the problems with the DRUJ. They talk about this 4-leaf flower treatment algorithm. What are these 4 leaves? One is the ECU. What it means is ECU can be contributing to a painful DRUJ or a pain at the ulnar side of the wrist. Second, the cause could be TFCC. So these are the 2 soft tissue causes, and 2 skeletal causes would be a cartilage defect in the DRUJ or a bony deformity in the DRUJ. Actually, all 4 would not exist mutually exclusive. They would overlap, and that is what exactly gives us a 4 clover leaf. So if we apply this 4 clover leaf concept to each of our cases, we would know what to do in each case and avoid a persistently painful joint despite surgical intervention. Let's go through a couple of examples. And before we go on to chronic pain, there are 2 conditions which cause acute DRUJ problems. One is a TFCC tear causing a DRUJ instability. So I don't know why the video is not working. So this was showing a unstable DRUJ, doesn't matter. The video is stuck. Okay, doesn't matter. So I'm sorry about this glitch. So when you have an unstable DRUJ because of the TFCC, it makes sense that we repair the TFCC and get the problem under control. So just to get this algorithm started, you take this algorithm, and we know that it's the TFCC which is a problem. So the TFCC undergoes either an open or a TFCC repair, and the literature says there is no significant difference, though Dr. Vikas Gupta made a very significant point about early return to rehabilitation. The second point is about the bony impingement that happens in the DRUJ after a distal radius fracture. Again, just to get used to this algorithm, it's a bony deformity. I do not know why the videos are not working. Are you seeing the video move?
No, Pankaj.
Okay, fine. So we'll just skip these videos. They were working fine when I checked it this afternoon. So you have the bony deformity. So we need to address this bony deformity, and this video actually was showing a maneuver to reduce this step. This needs to be done intraoperatively when you notice it. Otherwise, this is going to lead to a painful and stiff DRUJ. I do not know why this is completely getting stuck. I'm sorry, this is just not progressing. Okay. So the next issue is a volar dislocation of the ulna, the volar subluxation, the uncommon variety. This was a neglected one. Obviously, it was a very painful and a stiff DRUJ. By applying this algorithm, the problem was in the TFCC, so it would require repair of the open repair of complication. So this was one lady. She was about 70 years old. She was on long-term DMARDs for RA. She had this insidious onset swelling of the wrist and a very painful wrist, something which the RA seemed to be under control and it suddenly became painful. This was her X-ray. It was thought to be RA, so we did an MRI for her. And what you see is those tiny white spots are the bones, and this is a huge amount of synovium with fluid collection in it. So this patient has a TFCC problem because it was completely destroyed on the ulnar side. There is a bony deformity, there is a cartilage defect, and there is a complete involvement of the extensor tendon with synovitis on MRI. So all four. So in order to address all four, this patient would undergo wrist fusion with excision of the synovium. This turned out to be tuberculosis. It's not rare to have a secondary tuberculosis in patients who are on rheumatoid arthritis. She had a full AKT, eventually developed a stress fracture at the end of the plate, and underwent a revision surgery as well. This was another young patient who underwent a conservative treatment of distal radius fracture and continued to have a lot of pain in the DRUJ area. This was a comparative X-ray on the opposite side, so there is obviously a shortening. The rest of the parameters of the radius angle are normal. So again, apply the algorithm. So there is only a bony deformity, and there is a problem of the TFCC as well. This was an unstable DRUJ. So this patient underwent an open TFCC repair and ulnar shortening. This was a tension band and had an excellent outcome. So for DRUJ, for DRUJ arthritis, now we have these three options. One is a DARA procedure, one is a Sauvé-Kapandji procedure, and a hemiresection. No matter what we do, really, the problem with all these is an unstable ulnar stump, and eventually there's a radial impingement of the stump. This especially happens during loading. Remember, DRUJ is a load-bearing joint, so the ulnar stump keeps rubbing onto the radius, and it can be painful. The solution really to this problem is a hemi replacement of the ulna, or a total replacement, or a total DRUJ replacement. Unfortunately, I have no experience of these. These are textbook images, and these are not available in India. And I understand the shaker prosthesis, the total DRUJ prosthesis, costs about $9,000. Having said all these things, we know this protocol for DRUJ that we need to look at all soft tissue and bony problems. I still wonder why a patient who has only almost an invisible problem after a displaced radius fracture is united continues to complain of pain, and another patient in whom I have obviously caused a malunion of the distal ulna, there is a scalloping sign, and it continues to enjoy painless range of motion at the DRUJ for years together. This really stumps me. There is no cartilage involved in this movement at all still. So to summarize, we need to look at the repairable factors, the soft tissue factors, and the DRUJ cartilage factor, and apply it to this algorithm. Through this algorithm, we will eventually have four options for treating DRUJ problems. Either to repair the TFCC, reconstruct the TFCC, we do a hemiresection with interposition of the DRUJ, or we do salvage procedure like a DARA or a Sauvé-Kapandji. Thank you very much.